patient undergoes surgery. The lights power down, the procedure ends, and the recovery period begins. But the timeline that follows can be deceptive. When a new medical condition appears during this post-operative window, it is tempting to assume the surgery caused it. That assumption is often wrong. ICD-10-CM guideline B.16 governs these moments. It provides the parameters for documenting and reporting complications of care. On the left, a chronological timeline. A procedure occurs, then a condition develops. Chronology does not equal complication. On the right, causality. The procedure directly triggers the condition. Because an event happens after surgery, you cannot infer the surgery was the trigger. When a coder documents a routine post-operative event as a surgical complication, they create a legal record of a medical error that did not occur. This discrepancy is what auditors look for. It triggers reporting errors and creates severe compliance risks for the entire facility. To eliminate this risk, we will map out a decision matrix based on the logic of the guideline to evaluate any post-care condition. Medical coding is a legal and financial translation of the provider's care. It requires exact fidelity to the written record. Guessing or inferring relationships based on clinical context or your own medical knowledge is prohibited under these guidelines. As a coder, you must rely on the explicit text and the logic present in the documentation. Mastering Guideline B.16 requires applying a specific analytical framework to every chart. It demands that you verify the clinical logic before assigning a code. This diagram outlines our decision tree, beginning with the starting point of any chart review, identifying a post-care condition. From this first node, we follow the baseline rule of medical coding. All code assignments are driven by the provider's written documentation. It is the provider's responsibility to establish a relationship between the condition and the procedure. The provider diagnoses and establishes the clinical links. The coder reports the links that have been established in the text. This brings us to a common point of failure. Coders often assume a relationship exists when the provider has not actually written one down. Without explicit written confirmation from the provider, the algorithm stops. The coding process for a complication cannot proceed. If the documentation notes a relationship, we advance to the causality gate. To navigate this gate, use the MJ-GEM rule: no cause, no complication. This rule protects against the timeframe trap. A condition occurring during a hospital stay or after a procedure is a chronological fact, not inherently a complication. The regulatory requirement states the condition must be documented as occurring due to the care provided. Our decision tree expands to a logic gate. Is there a documented cause and effect? A coincidental cold after knee surgery routes down the negative path. To trigger the affirmative path, notes must strictly link the intervention to the resulting condition. Causality acts as the legal bridge between a medical procedure and the assignment of a complication code. Proving causality is necessary, but it is not enough to assign a code. The condition must also meet the next threshold: clinical significance. As the diagram shows, clinical significance means the condition must satisfy at least one of three criteria. It impacts patient care, requires additional evaluation or treatment, or alters the course of the surgery. Expected or self-resolving symptoms following surgery, like standard postoperative pain, fail this threshold. If a condition is caused by the surgery but does not demand specific treatment or alter medical decision-making, it does not qualify. To be classified as a true complication, the condition must tangibly disrupt the medical timeline and demand a clinical response. There is a common misconception regarding these rules. It is often believed that the provider must write the exact word complication in the chart. If the medical record proves both causality and clinical significance, the clinical substance overrides the lack of that specific word. However, if the documentation is unclear at any point in this matrix, you reach a failure state. This immediately triggers the mandatory query protocol. When documentation is ambiguous, querying the provider is a compliance requirement to resolve the gap and prevent audit failures. This is the completed B.16 decision tree, a tool for processing any chart. When a condition is identified, the cause is documented, and it's clinically significant, you have a clear path to assign a complication code. If causality is missing from the record, the logic rejects the code, terminating the process. And if the relationship is ambiguous at any gate, the system flags the uncertainty and instructs you to query the provider. Adhering to this visual matrix protects against audit findings and incorrect reporting. As you close out a chart, remember, chronology is not causality. Just because a condition follows care does not mean it was caused by it. Ask 2 questions of every record. Is this condition caused by the care, and is it clinically significant? You must prioritize the data written in the provider's text over clinical assumptions. Filtering every record through this algorithm ensures that your reporting accurately reflects the documented reality of patient care.